diagnosis of soft tissue lesions. Evelyn, take it up.
Yes. Are you able to hear me?
Yes, I can hear you.
Okay, thank you. So I'm Evelyn Tolo, a psychologist working at Kitale County Referral Hospital. But I wanted to say that I'm grateful for this webinar because it's going to shed light on our diagnostic procedures. And as a laboratory specialist with a vast experience in laboratory diagnostic methods, I felt it was wise to share what I know with our colleagues so that we can improve on our laboratory testing so that our patients can benefit. So today, I have this interesting topic. It's more of a discussion than a lecture, and kindly feel free to ask questions where you can. And also, I'll have a question at the end of this topic so that I can be able to gauge whether part of whatever I've taught is relevant and our participants have gained some knowledge on whatever I've said. So it's a simple thing, very common. This is what we do on our daily basis. Feel free to listen and welcome. So about the differential diagnosis of soft tissue lesions. My expectation today is that by the end of this, I wish to see that our participants are able to understand the definition of soft tissue lesions, also recognize the importance of differential diagnosis, identify common soft tissue lesions and their clinical features, differentiate between neoplastic and non-neoplastic lesions, understand the diagnostic approaches for each, then correlate the clinical, radiological, and laboratory findings for a definitive diagnosis, discuss common diagnostic pitfalls and challenges, appreciate the role of multidisciplinary teams, and also discuss a few case studies that we encounter in our daily work processes. So what are soft tissues? They are like the type of tissues that connect, they support or surround other structures and organs. I'm hoping that most of our participants here have gone through anatomy and physiology and they understand when I say they connect, they support, they surround other organs. And this includes mostly muscles, the basic muscles of the body, the tendons, ligaments, the nerves, the fibrous tissues, the fat component of the body, blood vessels, and synovial membrane. So they have specific functions. Each has specific function, but mostly they help us have flexible and flexibility, and also they enable movement. Some provide structural support. The others are usually they assist in protection of internal organs, and also they facilitate various bodily functions. Understanding these in terms of anatomy and pathology is crucial in laboratory differential diagnosis. So why is it important to have a differential diagnosis? Is it necessary? Yes, it is highly recommended because you have to differentiate whatever you are seeing, assuming you have found a sample. You have to understand this sample, whether it is benign or malignant. Benign is that benign things are not cancerous, but malignant lesions are highly cancerous. So you have to differentiate to see whatever you are doing, which method do you choose? And sometimes from our practices, we have found that a lesion or an infection that you see with your naked eye could be having many other infections in the same lesion. Like you can have 5 different pathogens present in the same lesion. And until you find them, then the patient will never recover. So some soft tissue masses sometimes appear similar clinically, with other masses. And then also laboratory tests such as histology, cytology, and immunohistochemistry can help identify benign tumors and malignant tumors. Like you are able to tell whether a mass that you are seeing on somebody is either a simple fat lesion or is a sarcoma. Sarcoma is highly malignant cancer. So this one also can help you differentiate between infectious agents versus non-infectious conditions. Like an abscess, if you have an abscess, you have to differentiate this abscess. Is it caused by TB? Is it caused by fungal infection? Or could they be together? Or they can mimic each other. And sometimes these symptoms can also mimic tumors caused by cancers. So we need to value other techniques like microbiological cultures, PCR, sedent stains, gram stains, and so forth to differentiate the infectious from non-infectious organisms. We also help, like after you do a differential diagnosis, you're able to avoid misdiagnosis. How? Most of the soft tissue conditions, even associated with autoimmune diseases, allergic reactions, parasitic infestations, can present similarity with other highly malignant diseases and infections. So mostly we employ laboratory techniques to differentiate and identify specific type of infections. And from this, you should be knowing that as laboratory personnel, we should not be limited on how we work. We should learn to interact with the clinicians. We should learn to interact with our patients. And if you are only given a specimen, kindly make sure that the request form has clear information concerning the patient on the type of sample that you have been given and where it has been taken from. And you should also be able to understand other clinical features of the client like age and any other underlying condition so that it gives you a way of thinking on how else can you help this patient. And I've one time seen a patient whereby the sample was brought for pus, very like 10 ml of pus in a syringe. And then after doing culture and sensitivity, there was nothing that was isolated. Then I hear people saying that this is sterile pus. We don't have sterile pus. It's only that you need to do a differential diagnosis on that pus sample so that you know whether it has something else. And for curiosity purposes, I decided to do gene expert, and I found it was highly positive for TB. And on further checkup evaluation, I did a KOH and I found it had fungi. So the same sample that was seen as sterile, we isolated TB and fungi at the same place. So laboratory techniques that we can employ here, we can have simple CBC, like full hemogram, and you check on differential count, you check on eosinophil count, you do serological tests, even simple things like VDRL, Brucella, they'll give you a story. Then we also do skin scraping in the case of superficial lesions, like on top of the skin. So also differential diagnosis guides appropriate treatment options. Whether you are going to, the patient is going to be given or to be done surgery, others are given antibiotics, others are given antifungal, others are given steroids. It depends on accurate lab diagnosis. So if we want to avoid unnecessary procedures on our clients, we have to do a differential diagnosis so that the patient is given the right treatment on timely basis. So we can also do differential diagnosis to monitor disease progression or recurrence. For malignancies, e.g., we have to do tumor markers, we need to see molecular tests to help monitor treatment options and detect recurrence if there is any. And sometimes a patient who has been treated for cancer of something else, in the long run, they also develop another cancer associated with the chemotherapy that were given. So until you do a differential diagnosis, you'll never know that they have different type of cancer. So we can also do a differential diagnosis to support imaging findings. Like a patient who has had who is showing something on X-ray or is showing something on ultrasound imaging could have a mass, but that mass is not specific for which one. So for a doctor or a clinician to be able to do like surgery or administer other treatment options, you have to do a lab diagnosis and you find that that mass is associated with something very common like TB, which does not just respond on surgery alone until you give them the right medication. So diagnostic approaches are varied. How do you do a differential diagnosis? One, you have to learn to do clinical evaluation. As a clinical cytologist, mostly we are encouraged, or part of our job description is to check on the client clinically. You should be able to evaluate this patient. Check on like, how does the patient look like? Where is the lesion? How does it feel? You are able to touch and feel the lump. If it's a lump or a sinus, whatever you do, you have to do clinical evaluation. Then you should be able to take history. Some conditions are acute, others are chronic. Assuming that you have a patient who has had a wound for 20 years and another one that has a wound for 1 week. You see, whatever you think about that wound is very different. One, it could be associated with cancer, and then another one is associated with an acute bacterial infection. So you have to learn to take history in terms of duration of the wound, if there is pain or not, if there was a history of trauma, and you also assess how fast is the wound growing. Is it very, very, very fast? And then you also check for systemic symptoms like lymphadenopathy, fever. It guides you on what else you should look for and what type of test to include in your differentials. You have to be able to do a physical examination, like the location of the lesion, the size, mobility. Is it able to move? Sometimes some wounds are highly fixed on the underlying tissues. Others are very mobile. Then are they tender? Tender means painful. And then how is their overlaying skin changes? Does it show color change? Is it inflamed? Is it just flat? You have to note. Then you also have to rely on imaging studies, which is non-invasive, which includes ultrasound, X-ray, MRI, and CT scan, depending on how the patient is showing. Laboratory investigations that we encounter for differential diagnosis. Number one on our list is CBC. You want to check for if there is any infection or inflammation, and you will check on perhaps the WBC count and other related like differential counts. You have to check also on the ESR, or for modern labs we are doing CRP. It shows the degree of inflammation or malignancies. Then we can also employ tumor markers when malignancy is highly suspected. Like which ones? If a patient has sarcoma, I'll show you what sarcoma is. The soft tissue inflammation. You will find that some specific tumor markers are employed so that you're able to establish the exact cause of the lesion. We also do microbiology tests. These ones mostly we employ swabbing and we do cultures, or we can aspirate pus and do cultures if you suspect that there is an infection. And then we do also TB tests. That's when I say that you get pus and it's negative for any growth. You have to think of TB, where you are doing SEDEN or you are doing genetics part. Sometimes the same sample you can do KOH if you are suspecting fungi, or you do fungal culture depending on your institution. And then if somebody is showing signs of allergy, you have to check on immune-based tests, which I'm going to talk about them. Then if you think it is cancer-related, mostly you do the tissue diagnosis, where you are either going to do fine needle aspirate for cytology. It is very quick and minimum invasiveness. Then you also is good for cysts, especially when you find that the limb or a knee joint has a lot of fluid. You can just do aspiration. You can aspirate an abscess or suspected malignancy. We also have where people do core needle biopsies. This one is very preferred for suspected malignancies, and it preserves the tissue architecture for histology. And we can do even excision biopsy, whereby you are removing the whole tumor, then you take it for histology diagnosis. So in histological and X-ray testing, mostly we do routine histology. You want to determine the cell type, pattern of cell arrangements, and malignancy if you are suspecting malignancy. Then furthermore, you continue doing immunohistochemistry. You want to identify the tumor origin. Sometimes a lesion can appear on the soft tissue mass as a soft tissue mass when it is just a metastatic disease from the internal organs, even from the stomach or from the gastrointestinal tract, or occasionally from the cervix or ovaries. Then you see it on the skin. So you have to make sure you identify the lesion accordingly. Then for further checkup, you can go in for molecular tests or genetic tests depending on the type of lesion identified. So what happens in real practice? Like what do you do at your workstations? Mostly in a suspected case, if it's an infectious swelling EGTB, you are thinking of TB, then you have to do blood work where you are starting with like hemogram, then it shows something, then you send them for imaging, and then you do TB stains, GeneXpert. Then if a person has a painless lump, like somebody has a small swelling on a limb that is not painful, it is growing slowly, what you need to do, mostly for cytologists, you do fine needle aspirates or core biopsy for histology. Then occasionally you find that a patient develops a very rapidly growing or painful mass, like on a hip, on a buttock, in a breast, or whatever place you might find. If you are available for some advisory committee, you have to make sure this patient is done an MRI or a core biopsy so that you establish the cause. Then occasionally a patient can come in with a post-trauma swelling, like something hit or he was pricked by a nail and others. This patient should be checked on an ultrasound scan to rule out hematoma. Hematoma is just a swelling that is full of blood, or sometimes a patient could be having a muscle tear. Then if you are suspecting allergic reactions, assuming the patient took some medicine and they come with urticaria, they are itching and they are having like a lot of issues with their skin, you start with a complete blood count. You will find that on a differential count, eosinophils will be very high. Then you can recommend for serum, IgE, for clinical chemistry and other evaluations. Then if you are suspecting fungi or parasitic infestations, one, you can do a lot of good things using potassium hydroxide solution, which is very cheap, or you employ fungal stains. Specific fungal stains are there. And also you can do a stool examination for parasites, because assuming somebody has some lump on the skin and they have infection of some cystodes, like for animal cystodes, you'll find that they have some of the masses on the back and others will have masses even on the face, only to find that it was just a parasite. So be happy that once you have a patient, think like you are thinking 100 times. You have to find what is this, so that you don't just get skewed and only do one test on that client. It could be a wound. Make sure that you employ most of these techniques at the same time, such that within 2 hours, you are able to get like 5 things from the same patient, and the patient will recover faster. So key points to consider during a differential diagnosis. One, you should be able to do a physical check. If you don't have a patient at your workstation, then you have a request form that looks like the patient in terms of all the information should be available on that request form. Two, you should be able to collect good sample and prepare it accordingly. Because if you are going to do a differential diagnosis on a patient, there are different types of collections you are going to do. On the same wound, We will first perhaps remove for cytology, then go in for TB tests. Then for culture, you have to clean that wound thoroughly before now you pick the smear for culture and sensitivity. And if you mess in any of those, then you are going to culture a wrong organism, a contaminant, and you give a wrong diagnosis. Then you should be able to recognize things on the microscope in terms of what do you see. You should be knowing what you are looking for. Even if you do a KOH on a wound sample and you don't know different types of fungi, then your diagnosis is zero because you will not see them. So learn many other things that you are not taught in school. You should be able to identify like 10 types of fungi patterns on a microscope. That's how you are going to give out a diagnosis. Then you should also be knowing auxiliary test techniques. If you happen to see like bacteria on a gram stain, do you stay there? No, you have to continue now doing culture and sensitivity so that you are able to identify the exact bacteria and its exact medication. And also, you should be able to rely what you find on clinically, and it should match with the laboratory things. Also, put in mind how you report, how you advise the physician or the clinician, and remember to do quality control on your procedures. So categories of soft tissue lesions, we have neoplastic ones. These are tumors. A tumor is a growth. Anything swelling, we call it a tumor. But now you have to differentiate between a tumor that is cancerous and a tumor that is benign. Then you can also have infectious diseases like bacteria, fungi, parasitic, including leishmaniasis, TB, fungi, and others. You should be able to say that this patient has an allergy based on how you see it by doing immunological tests. You should be able to isolate arthropods. If you don't know how an arthropod looks like, you won't find it because these are organisms that you see on a naked eye. Either you can see them under the microscope, you can see their nits. Nits are just eggs, small eggs, either on the skin surface or inside under the skin tissue after you do a scrap. So most of the arthropods that we find that are never mentioned in our diagnosis, myiasis, a very common one, secondary infection in wounds and in cancer patients, we have a lot of myiasis, tungiasis, scabies, and lavimigrans. There are many other types, even mites. Then you should be able to say that this is a reactive lesion. Like if somebody was pricked by wood particle and it was never removed from that surface, it means the patient will continue having a reaction and they can form a very big mass. If a doctor is not careful, they can amputate a limb of a patient because they have some wood particle inside their muscles. So as laboratory personnel, we should be able to understand all this so that we give the right diagnosis. So what do we expect in differential diagnosis? We have to understand there are so many bacteria, there are so many viruses, parasites, malignancies, benign lesions that don't look like cancer, but they grow, arthropods, allergies, and foreign body reactions. So benign soft lesions are varied. Those that are non-cancerous, but they are seen, arise from the body soft tissue, connective tissue, including what? Fat. In our body, there's a lot of fat. There's fibrous tissue, we have muscles, nerves, blood vessels, lymphatic tissue everywhere. So they don't invade surrounding tissues or they don't metastasize to other body parts. And the simplest that everybody should understand is a lipoma. A lipoma is a small swelling associated with the fat accumulation associated with pressure. Like if somebody was knocked by something, they develop some swelling, which is very simple, not painful. It's called lipoma. We also have fibroma. We have hemangiomas that are found on blood vessels. Neurofibromas mostly develop where the nerve endings are and on top of the skin. Schwannomas, we have leiomyoma. Don't worry about these terminologies. For cytologists and histologists, they know what I'm saying, but when you see this, don't worry, but learn that they are there. We also have malignant tissue tumors, and we call this one sarcoma, very common. Sarcomas can develop from different lines. As you can see this picture, we have sarcomas developing along the lymph vessels, like on the shoulders. Others can develop on the nerve endings. We have those ones that develop in the blood vessels. Others will develop in the fat. And when I say fat, fat is almost everywhere. So you can have the sarcoma of the breast, of the whatever there is fat. Then we have common ones along the muscles, tendons, ligaments, and cartilage, especially where we have joints. So these sarcomas are highly bad cancers because they grow like bushfire. You can imagine if cancer is developing on blood vessels, what will happen? Because there is blood flow every time, they will metastasize to other parts of the body and the patient can present with any type of sarcomas. Then we have those that develop on the trunk, on the other side of, especially on the back. We also have soft tissue lymphomas. Lymphomas, as we know, they are developing in the lymph node lines, but we have those that develop on the skin. And if you see this picture, mostly you'll say that this is a skin cancer, or you will say it's just a fungal disease, but it has a story. For such cases, if a patient presents with this one in our skin clinics and they are referred to the lab for KOH or skin scraping, you have to be anxious that this patient could be having something bigger. And you see now you have to recommend for a skin biopsy or cytology. And you'll find that this patient has a lymphoma. If you do like hemogram on this patient, everything will be normal because lymphomas don't invade the blood system, but they travel along the lymphatic system. So be aware that any swelling or whatever you see on a patient has a story to be told. And you, for your information, this story or whatever the picture you are saying could even be associated with even skin diseases like fungi, leprosy, and others. So the best thing to do is to have a comprehensive check on such patients whereby you are not limited to only skin scraping, but you can also think about skin biopsies, skin snips, and other tests for reference. Reactive, sometimes we have just reactive conditions. They look more of cancer, but they are not. And we have so many, we have epidermoid cysts. These ones mostly grow in the hair follicles of the skin, and they form a certain pattern. But on cytology, they're just squamous cells that are dead. You can't find anything more than that. Sometimes you can have fat necrosis. Fat necrosis is like after somebody is injured on the surface of the skin, the fat muscles get rotten and they form something like a dead body. So they are there. Sometimes you can get an abscess or an infectious granuloma, highly associated with many things, bacteria, fungi, mycobacteria, infections, and occasionally you can have an abscess in cancer. So don't just take for granted that you're only going to do culture and sensitivity on an abscess. An abscess is a story. Whatever you get out of that lesion has a story to be told. So expose this on many other tests because I do find out of mycobacteria on the skin surface that nobody knows because they think that patients with the TB are only coughing and they have loss of weight. Some TB is just on the surface of the skin and they continue staying with it for many years, just now infecting other. Clinical presentations of soft tissue, they vary depending on where they are. Anything, it could be a wound, it could be an abscess, a swelling, a sinus. A sinus is just a small opening on a body surface. It doesn't matter where, but there is a sinus where it discharges some pus slowly, daily, for many years. I found a patient with a sinus for over 20 years who has spent everything and there was no diagnosis. Then I find them, I aspirate pus like this. Then on the microscope, I only find TB. Over 20 years with a sinus that has never been treated because nobody knew that TB could be part of the problem. It could be a crust or a skin discoloration, whereby this change of color. So anything that you see unusual on a body surface needs a differential diagnosis. And in case you are given pass, like this one. This is a storybook. I usually say that pass in a syringe to me is a storybook because I'm going to now check for many things and I'll find them. First, I'll start with cytology. Then it shows me there's a lot of neutrophils. Sometimes you just go in for cytology and you find malignant cells in an aspirate like this one. So from today, whoever is listening to me, make sure you are checking for everything. Sample collection techniques vary depending on whatever lesion you have seen. If it's something that you can see, you can do exfoliative. What's meant by exfoliative? You just scrap off freely the cells of the body without using outer force. You can scrap, you can do imprints on an open ulcer. You can do swapping. Or if the lesion is hidden, it's like a mass, you have to do a fusion, you aspirate. You can do fine needle aspiration. And if it is deep inside the muscles, then you have to advise the doctor, they do a biopsy or skin snips for further evaluation. About the procedures that we can do, there are many. We have macroscopic examination. It gives you a story. Like a sinus that is like that, to me, I'll be very happy to check how it looks like. Then I'll go in for TB and fungi. Then if it is something that looks malignant, you will choose your techniques accordingly. So you should be learning on what to do on the microscope, culture and sensitivity hemogram. Then the other special things like methylene blue stains, very beautiful for bacteria, simple techniques, KOH for special fungi, Romanowski stains for Diffquick, because sometimes you do FNA on a patient and you only find leukemia cells from a mass. You can employ cytology techniques, histology, molecular techniques, immunos, flow cytometry based on what you have seen, and gene expert and fear test for leprosy and other techniques. So types of sampling techniques are demonstrated here, where we are doing fine needle aspirate using a small needle. You can do scraping using a brush, and you can also make an imprint, and you can also use the sample that you have been given to aliquot for other tests. Staining, depending on what you suspect, you can do perpendicular stain, you can do Romanowski, you can do other special stains for the TB, gram stains, water and sterile if you are suspecting something like syphilis, because the person with syphilis sometimes have changa. You can say had changa, they have lesions, and you want to differentiate that changa from malignant lesion or from even brucella. The brucella people also have some form of granulomas. You can do fungi stains like gomorimethamine stains and periodic acid still, if you have seen a fungi on KOH and others. Common pathogens, we isolate protozoa, fungi, bacteria, tumors, we get parasites and arthropods. Characteristics of cancer cells, like after doing FNA, you have found some cells, then you are wondering, now what are these? Cancer cells are known to have specific characteristics. Normal cells are usually very smart in terms of arrangement, size, and how they look like these ones. But if they become cancerous, they change their shape in terms of the nucleus and the cytoplasm and the color and even the nuclear membrane and the nucleoli presence. It gives you a story. Then you will also find that there are so many dividing cells. A normal cell divides at certain sequence. But if the cells are cancerous, they divide very quickly and they produce beautiful things called mitotic figures. Like this one is a mitotic figure and it shows a high lesion, mostly associated with malignancy. Then they also vary in shape and size, and sometimes they lose the normal structure. They look like they are not cells, but they are cells. And you can see these ones, how they look like. They don't look good. Each cell doesn't look like the neighbor, and this is a feature of malignancy. Still features on malignancy, after you do like FNA or whatever you are looking for, you find that there's a lot of cells. There are many cells on the microscope. That's a feature of malignancy. Then you also check for cellular enlargement. nuclear cytoplasmic ratio like these ones. You can see how they look like, they look bad, and others. There are many things you are going to learn about cancer cells. So we have a few case studies that I've outlined here so that we are able to move together. These cases have been picked directly from my case studies that I've handled. And this is a baby, 4-year-old baby, who was born very normal. Then at the age of 6 months, she developed rashes. Like you can see on this her scalp. This is how she looks like. So this baby has so many lesions. You can see they look like masses, big ones, and the skin is rough with so many things. Apart from this, the hands and the limbs, the legs are fully eaten up, and the fingers have been merged together so that you cannot separate one finger from the other one. Then this baby was sent for cytology diagnosis. I did a fine needle aspirate. I also did some skin scraping, as you can see. And since she had some open limbs or open wounds, I decided to do scraping and also did some imprint cytology. But what I found on the microscope shocked me because I had never seen something like that. Because whatever I saw was this organism here. First, I saw these ones are called nits, the eggs. I saw so many of them on the slide. They are very characteristic. I couldn't miss them because they are very, very smart. Then on my check, I also found this organism here with several limbs like this, oval in shape. Then I ran fast back to my laptop to confirm what I had seen, and it was just a mite, each mite. It can cause such havoc on a baby who has been treated for 2 years without improvement because nobody knew what was eating this baby, only to find that it was an itch mite. Then on cytology, I find something very weird, similar to cancer of the skin of the scalp. But now, since I was not doing histology, I referred this patient for further evaluation. But the main suspect was the itch mite, which is very common. Nobody thinks about itch mite nowadays. They think of big things, cancer, they think of COVID and other things, but they forget the simple things. So they will cause small papules, nodules, like you can see here, with intense itching, and then they can mimic dermatofibroma. Dermatofibroma is a cancer of the skin, and you see when I wrote a differential diagnosis, I indicated that they have to rule out something like this. But what I saw is very beautiful, very cheap to treat, and we had never discovered such. Another case is another lady who came with a complaint of skin issues. You can see this one. This is her face. Very painful for like 2 years. Nobody had seen this. And she was being treated by steroids with a diagnosis of skin disease allergic condition from a dermatologist. And they said her condition can never heal. So she had used a lot of steroids and she was in pain. So I did the simplest thing here. I only did a skin scraping and I only found these things. They are very, very smart things. You see them, they are not just the diagrams. These are called dermatoid mites. In reality, this is how they look like. It's an insect. These are insects and they like eating your eyelashes. If you have eyelashes that are itchy and painful, some are red, you just do a skin scraping, you'll find them. So it's a simple thing, but nobody thinks about it. Dermatologists don't send patients to laboratory because they know this is an allergy, psoriasis, and they have different types of explanation to their clients. So if you miss this one and the patient is sent for some further checkup, it looks more of psoriasis. To me, from my practice, I think we don't have allergic conditions. We have things that cause allergy, but they have never been known. So I want you from today to go and do it practically. A patient presenting with any skin rash, you do skin scraping, you do KOH, then you give it time to digest like for 2 days. You centrifuge check on your deposit, you'll find these things that I'm talking about. This one is a latest case that I had recently, like 1 week ago. A patient presenting with a lesion. This is the ear. It has been eaten up, all of it. And you can't see anything here. So this patient comes in for cytology diagnosis. And I'm like, what could be the problem with this one? So this one was very easy to pick samples because it's just an open wound. I do a lot of, like I just do cytology, I do imprints. But in my procedure, I discovered there is something that is moving inside. Then I call a clinical officer to check for me. Then he advised me to apply hydrogen peroxide. He does it himself. And then they come out like 1,000 of these. These ones are called myiasis. This is a condition called myiasis. Myiasis is just infection. Infection by certain type of larvae, fly larvae called Dermatopia hominis. Very common. If a wound is left open like these ones, the flies will come and they lay eggs here, and the eggs will develop into maggots. And this is how they look like. Like we got like 50 maggots from this wound. Some even have eaten inside the skull until you can't find anything. It's only the bone and some of the surrounding tissues. Now, what did I do with this one? I did cytology, I did KOH, I did gram stain, and now with the myiasis on my diagnosis, then I find beautiful things. One, on KOH, it gives me this structure, which is a septate fungal hypha. Septate in that it has septations like sugarcane plant. Several. This is just a small picture I've taken from the microscope. Then I also do gram stain and I find only blue staining bacteria cocci, which I didn't go any further. And then I find cytology, I find squamous cells, which are very, very malignant, giving me a diagnosis of cancer of the skin. 2, it's infected with fungi. It is infected by bacteria and also by maggots. And this patient is alive. So that's why I'm saying that even if a patient has cancer or he has fungi, think of TB. I did TB, it was negative, but all other things were present. So for arthropod-related lesions that mimic cancer, we have many. Myiasis, the way I've said, it's usually a condition caused by larvae of some types of insects. So a patient presents with painful nodule with central puncture, meaning there is something like a small hole. You have a big mass with something like a hole there. And then the patient will tell you that there are things that are moving inside my lesion. So what do you do as a laboratory personnel? You do in visual extraction. You can send for ultrasound, and then you'll see that there are so many larvae inside. I'll give you a story as we continue on somebody who was to be done breast surgery for mastectomy because they had a mass, only to find it was myiasis. Then we have also jiggers, we have scabies, the way I've said, we have cutaneous staph migrans, tick, grandomas, lice, and the other things that you read on your own. This is another case. I found this one in last year. This is a lady, 44-year-old or 37-year-old female with a chronic ulcer on the scalp of the head, like this one, who had been having this mass for 2 years. And what I could only sympathize with this lady because there was pus streaming on her face and everywhere daily for 2 years. And there was no diagnosis after she had been given a lot of antibiotics. There was no response. So when she came, I had to do a differential diagnosis. I just did culture. I removed the sample for culture, for cytology, SEDEN, KOH, and HIV. For culture, I was imagining this could be having a very beautiful bacteria growing for 2 years. Then cytology, I suspected malignancies of the scalp. So then I suspected TB, KOH, I suspected fungi, and HIV test, I suspected because she was very thin and she looked very sick. And like everything that I requested for was positive. But cytology was negative for malignancy, but she had granulomas and other issues. But now what made me happy is that immediately I went on the microscope for SEDEN. I found a lot of acid fast pus, which was SEDEN positive. I also wanted to confirm. I aspirated more pus for gene expert and it turned out to be positive. And even fluorescent microscopy, it was positive. Then for culture, the report showed Proteus mirabilis. And then also for KOH, I found a lot of these septed budding yeasts, as you can see here. So this patient was having everything. And then I tested her sugars. She was also having, she was diabetic. So I did like 6 tests and all of them were highly significant for her progress. And she went home with like 10 types of treatment options. She was sent to chest clinic, AMBAT for HIV treatment and follow-up. Then she was treated for diabetic clinic. I sent them and she came back after 2 weeks when the wound was closing up. I have many stories, but today I've just picked a few. This is another case. A 70-year-old female with so many skin lesions coming for cytology. Some had sinuses, as you can see. A sinus is a small opening on skin surface. Then I cannot tell everything, but whatever I found here was just TB. TB, she had found painless subcutaneous and red-brown nodules, which could advance to ulcers and discharge sinuses, meaning she was discharging a lot of TB. And on cytology, mostly it gives you direction that this sample that you are dealing with, check. And then I found a granuloma. Granuloma is a special configuration on cytology films where we are having a lot of histiocytes with some necrosis in the background. And it gives you a direction to whatever condition the patient is having. So this is another one, an 18-year-old male with a fluctuant mass. Fluctuant means you touch it, it sinks. It's like soft mass. Then a clinician had written that this is a lipoma. Lipoma is a soft tissue mass that is benign associated with fat deposits. But on FNA, then we get a lot of pus. And this pus, now we subject it for culture, we are doing cytology, we are doing KOH and gram stain. But it only showed septed filamentous hyphae, specific with acute angle configuration. Acute angle, you should know how they look like on the microscope. If it's dividing, it is dividing at acute angles. That's specific for cutaneous aspergillus. Very simple, but very dangerous. Until you give a right diagnosis, this patient will not heal. Assuming this patient, we didn't get anything on gram stain, we didn't get anything of significance on cytology because it was pure pus. So KOH gave us a story. Then we could continue forward and get that this one were aspergillus. This is another story. This is a trunk. I hope you understand a trunk. A trunk is like you cut the limbs, the upper limbs and the lower limbs. Then you remain with the part of the buttocks as you go upwards towards the back. This is a patient who has had issues with sinuses. A sinus is just an opening where there's some discharge of pus, blood, and water. And there are several. Like you can see here, there are several sinuses. If you puncture here, it gives you pus. You puncture. But this pus is highly specific in terms of how it looks like. It has yellow sulfur granules. You can see them. These are not stories. Then on just simple things, gram stain, it gives you filamentous. This one. Branching gram-positive filamentous. This one, like hair, like cotton wool. Very specific for actinomyces. But on other things like cytology and others, because of the past content, you can see something better. So this patient, you subject them on different types of techniques and you find what is killing them. This is another one. Slowly enlarging varicose plaques containing multiple small abscesses like this one. If you are given this patient for you to be able to do what you want, you have to feel it. And after you feel it, you are able to extract something, either fluid, blood, or these hard crusts. All these are specimens. And sometimes a patient can be infected by something else. The original pathogen is different. Then because the masses are outside, other bacteria will come in and colonize this wound, such that when you apply the specific medication, the patient will not heal until you find the other enemy inside. And we only find beautiful things like this. These are called blastomycosis. They are specific type of fungi that cause severe invasive mycosis, meaning they're able to penetrate your body system up to the inner part of your body, and they will cause severe cutaneous fungal infection. This is another one. These patients are there. You cannot tell me I've never seen them. But what do you do about them? Like nowadays, when you meet on the road, you find such patients. And the clinician will just say this is loss of color of the skin, melanoma or something. But they have never done a bacterial, like something like diagnosis. This leprosy, beautiful pictures. Long time we knew that leprosy was just like affecting the extremities, the limbs, the last fingers and the ear lobes and some part of the nose. But from today, you know that leprosy is life and it is everywhere. Even at Nairobi, in the capital city of Kenya, we have leprosy. And this is how they look like. I've done several skin things and I find they're then positive, but I never knew that occasionally you should check to know the specific type of, like which bacilli are these, because these patients are found in our chest clinics and some have even given up because they know what is eating them. There are several characteristics for this one, but remember for such patients, you do a beautiful skin scrub, you dissolve whatever you have found, then you subject them for gene expert, you subject them for TB, you subject them for fungi, you'll find them. And sometimes cancer of the skin can appear like this. We have lymphomas and leukemias, like leukemia cutis, where you find such patients. So differential diagnosis for this one, you have to do a hemogram, you have to do a skin smear, you have to do, and you'll find that you have a problem. You should never give a patient that no organism isolated and you remain there. It means you have done zero work. Think further, what could be the problem? Because the patient cannot look like this with no organism seen. You can even refer them for histology so that they can be taken a sample and processed. It will be easy for this patient to get the proper medication. You will read these notes yourself because with the time, we cannot go in explaining everything. And this is part of our patients. This is a vagina, partly anal region of a lady who presents with lesions. You see such lesions, they look very simple, but they have a story. So for cytology, mostly you find this, you should think about HPV infection. And what do? The best thing to do, you can do pap smear, you can do vaginal scrap, and the process for cytology, and these are the best cells you find. They are called coilocytes, where we have nuclear thickening, irregularities, with some perinuclear halo around these are just epithelial cells that have features for viral changes, specifically HPV. Something like this, very easy to diagnose. This is another case that I found recently, like 1 month ago, that 2-year male who had an accident, like he was burned with some chemicals, like 5 years back. Then the patient healed naturally, but after like 6 months after healing, a small lesion appears on the site of where the wound was. Then it is very aggressive. As you can see, this is a leg like this, and this wound is like it has eaten 3/4 of the behind of the leg. And what makes me happy is that once you know the clinical presentation of some condition, you don't think big, because like this one, you can see this wound is very specific. It's forming a flower pattern, like a rose flower, which is a characteristic of cancer, specifically squamous cell carcinoma. Then we do cytology on this wound, FNA and imprints, then we get these clear cells. Beautiful but dangerous. They are just specific for squamous cell carcinoma, which is very highly, it is bad. And the patient was managed well. He was amputated. Already, he was amputated 3 weeks ago, and I'm sure he's going to pick up. Assuming that we left this person just to go for cleaning and dressing, the cancers would metastasize through either the bloodstream or through the lymphatic system, and it will go further, and this patient will not even benefit on amputation because the cancer would have gone to other parts of the body. This is another one. I saw him 2 years ago. A beautiful case, but very frightening. The major issue here is this one at the heel side. A beautiful but bad one. These are real cases. And this one I did just cytology. To me, it was direct, like you are given a direct question to answer and you get 100%. A characteristic skin cancer associated with the melanocytes. Melanocytes are the cells that form the melanin pigment of the skin. So for Africans, we have the black skin, and mostly when we have cancer of the skin, the lesion will come out with this black pigment, and it is like growing outwards, and you cannot confuse this with a bacterial infection until you do a differential diagnosis. Perhaps we have some other infections like fungi that produce also black pigments. So you have to rule out. But for this one, it was straightforward. On cytology, this is what we find. Mostly we find these histiocytes that have a lot of melanin pigment inside the cytoplasm. But now, because this is a smaller picture, when you make it bigger, you will see that there are cells that are showing melanocytes. They are like polygonal with some nucleus and nuclear membrane, with some having prominent nuclei. And then we have this one that is very common. I'm sure even my listeners, some of you have these ones. They infect nails. But how sure are you that this is which type of infection? Is it bacteria? Is it fungi? And we also have some melanocytic tumors, that cancers of the skin that can start from the nails. And this is how they look like. We call this onychomycosis. It's a fungal infection of the nail unit. Why connective? Soft tissues, because around this nail we have tissues. So this infection starts from the nail beds around here, and they eat up now the nail as it grows slowly and slowly. So for you to be able to find this one, the best sample to take, if there is pus around here, you isolate this pus and put for more tests, especially culture, you do KOH, you do SEDEN, because we have also isolated TB that eats up the nail beds. And we also have some cancers that also develop at the nail beds. As you can see here, it could also be a sign of drug reaction. Perhaps the patient was given some penicillin or Herceptin and they reacted on. Mostly it affects the nails. A symptom of hypothyroidism. So you need to do thyroid functioning test as a differential diagnosis. You have to rule out nail malignancies, contact dermatitis, and psoriasis. So many things, beautiful, but anytime you see a patient now, you have to think better. These are patients I saw. They came with lesions. These just a few pictures, but I have many. Now on FNA, I only find these. This is an indicator of cancer cells, but hematogeneous, meaning it's a leukemia process. So you are shocked to find such picture on a microscope. Then you go back to the patient and do full hemogram, only to find that they have like 300,000 WBC count. A very good indicator, such that now after you do this one, you refer them quickly to the relevant facility for other tests like flow cytometry. They are going to be done bone marrow spreads and they'll be put on cancer treatment and their conditions will improve immediately. Last but not least, these are patients that I saw physically. They came with a complaint of a mass for 2 weeks, very painful. But on close examination, it was a draining pus and a little bloody mixture. Then on a close range, I saw there was something like an opening. Then the patient was highly convinced that it was cancerous. So she told me, kindly help me find my stage. Which stage is this one? Before I die, I should be knowing what I'm dying up of. Then I told her, this is not cancer until I prove it. But she insisted because some doctors who had come for a free medical camp had requested that they go and cut off all the breast because the cancer would metastasize to other parts. Then after she called me, I told her not to try that until I prove it. So when she came, I wanted to see it properly, so I applied pressure here, firm pressure using my gas finger. Then I saw some discharge. It looked more of pus and blood. So with my curiosity, I wanted to find out what's inside the pus. So I aspirated all the pus and all the secretions. But before I could finish, I saw something black coming out, then whitish. Then I had to apply more pressure. And just think about this. Because I just found this one coming out and it was big and it took off immediately. I removed it from here and the patient was shocked. Like she almost screamed because her mind was already showing that she was having cancer. But I only get this maggot, which is part of myiasis. So if I were just to go forward and do a fine needle aspirate on this breast, then I would have ruptured this parasite inside this wound. And I'll now release more of this to infect her whole breast, and she will end up dying slowly because of the maggots, not because of cancer. So simple things first, think simple things as you think of big things. And now this is a case for us but I want everybody here, because I know who you are here, I'm going to call your names. These are 37-year-old male who presents with ascites. Now, assuming that your facility, we want to have a discussion on differential diagnosis. What could you do with this patient? How will you give out a diagnosis? So let me look for participants here. We have Ada, Frederick, and Nelly Okada, but we have others. So my discussion has ended there. I want to discuss about this case so that we know whether we have gained anything or not, because you cannot speak to an audience that is not speaking to you. Perhaps you have not even heard anything. Nelly, back to you.
Thank you, Evelyn. Thank you for the wonderful presentation. From the comments, it's outright that you've done a really good job and you've changed the minds of many. Now, some are saying that they really love laboratory work. Some are saying that they really love cytology. Thank you for the good presentation. Thank you so much. Participants, there's a question here that we need to discuss. Even as you ponder on that, Evelyn, kindly check on the list and come up with a name or two of people that will be answering that. Even as we ponder on that, I will want us to make us know of some few housekeeping of LMSK concerning these webinars. we are benefiting from them, and you can see how the quality of presentation and even the presenters are coming through. And I would like to ask you to inform your members, your colleagues, your friends to join up and learn. Here we are learning and we are challenging ourselves in our profession, medical lab sciences. So help your colleagues to come, share the link, share the registration link with them, and it's very easy to enter and to register. So, and when you register or when they register, kindly inform them to use their full names and write it correctly, their ID number, their KMLTTB registration number, and then they submit it. And then they will receive an email by the email address that they give. And remember also that these webinars are KMLTTB accredited, and they attract 3 CPD points. And within 24 hours, they should be auto-reported within in your portal. So you need to check your portal, your KMLTTB portal, within 24 hours, and they will be reported there. And certificates of participations will also be sent, are usually also sent to your emails. And the webinar, I've seen people asking for slides and all that. Kindly, the webinar is usually streaming live on the YouTube channel, LMSK YouTube channel. So kindly log into the YouTube channel. You'll find the presentation there. You can follow it slowly at your pace and revise and read on the different topics that have ever been presented here. And also for you to be eligible for the CPD points, you must have attended at least 60% of the session. Okay, that's one thing. And also we encourage you to participate by signing up on our LMSK Learning Hub. And it's a one-time sign up and gives you seamless access to all future events and learning materials. So those are some of the things that I need you to know. So Evelyn, have you identified any name of a person that you want us to help in discussing this case?
Yes, Martin Njuguna.
Okay, Martin Njuguna.
Yes.
Martin Njuguna, kindly take it up.
Is he on or not? Hello?
I'm trying to scroll his name around if he's there. Martin, is Martin in the house? It seems he's not on.
David Kaino?
David Kaino? In the meantime, Evelyn,
yes.
as people are pondering on that case, I will request David, there are 2 people that have raised their hands. Oh, yeah, David Kaino is here.
Kindly let him discuss this case, like how will you handle this patient?
Okay, David Kaino, kindly take it up. 5 minutes. Okay, David is not unmuting, so I would like to request David. There are 2 people that have raised their hands, David and Matthew. I'll give you 2 minutes each. So David, kindly unmute and ask your questions or give your comment. David Kevolwe. Sorry, David Kevolwe. Yes, David Kevolwe. Good evening, David. Okay, yes.
Good evening.
Yes.
Good evening, everyone.
Yes.
Good evening, David.
That was a very good presentation. It was very educative. In fact, we who love cytology, we were very much happy about all the things that she mentioned. But I didn't have a question, but I was just commenting and saying that it was thumbs up. That was a very good work from our presenter.
Thank you.
Sorry, Matthew Simiu. Thank you, David. Matthew, kindly unmute. Matthew, you can unmute now. Okay, let me go to the chat. To the
excuse. Are you able to get me?
Yes, Matthew, kindly 1 minute. Yeah, we can get you 1 minute, please.
Okay, now from the case, on my perspective, I think first of all, this is looks like pus that has been removed from that area, and the first thing you can do, maybe you can do gram staining on the sample. Then it can also be done for KOH to check if there are fungal elements. And then also the staining for TB. There's high likelihood that probably there could be a case of TB within the area, and now doing the DEN will be able to help in terms of checking if there are acid-fast bacilli and any other like other stainings, like for other Romanowski stainings, and also even like hematoxylin and eosin staining. I really want to appreciate Madam Kutolo for the powerful presentation. She's really an inspiration. And this one is really enlightening for us who are really looking forward to even in advancing in lab medicine. So it is superb. So that is my attempt. There could be more areas to check, but in my perspective, I will do the culture, then do the ground stain, do the DEN, and any other. Thank you.
Thank you, Matthias, for that. Wonderful. If I were to mark, I could give you like 99%.
Thank you.
And I hope you are going to do it from today, not just seeing this picture for fun. I want to make you change your capacity of how you think about patients. You should never, a lab personnel should always learn to interact with the client, whether doing a PS or whatever test you are doing. If you have an opportunity to talk to a client, kindly talk to them, because they'll give you a story, and that story will give you a diagnosis. You will not struggle even looking for what is killing this somebody. So Matthews, thank you for your response.
I really appreciate, and may God bless you. We will need more of this, unless it is an eye-opener for us, and it makes us even go deeper. Sometimes you can be able to see these cases, but getting to do the differential diagnosis, as we have seen, sometimes we are limited. You see a case and like you are not able to go deeper, but now with this kind of eye-opener presentations, I think it will help us even go deeper and deeper in terms of ascertaining and looking deeper to see and to give patients the ultimate diagnosis for better management and treatment.
Thank you.
Thank you.
So,
Thank
Madam,
Thank you, Matthew. Yes, Evelyn.
I was saying that
I would like to take questions.
Okay. Ideally, he has done what we want to do on this one. Apart from that, if he was the one who had seen the patient first, he should even refer for imaging studies, like for ultrasound or X-ray. This patient could be having a mild diseases. Even he could be having a tumor in the stomach that has ruptured or metastasized. So I know on Romanowski stains, you are able to identify cancer, but it could be easier for imaging studies because where could it be the cancer coming from? Then that's the treatment site. That's how treatment starts. So I want us to think like doctors. We should not just be limited with stool and urine as our samples. Think like a doctor, be able to examine a patient, be able to refer, be able even to discuss your cases with the multi-teams. Like you have a radiologist, you have a doctor, you have a physician, you have a lab consultant, and you are also there, even if you have never advanced, but you know what you are doing, you have to be on that board. You discuss this case, and now the patient comes out wholeheartedly as a healed person. I hope I'm very clear. Yes, thank you.
Thank you, Evelyn. You're clear on that. Now to the questions on the question and answer chat. The first one is, what is metaplasia? That's the first question. I will want, yes, what is metaplasia? Briefly, Evelyn.
Metaplasia is in cell division and growth. Cells grow, but with the time, they can change how they grow or how they look like based on the surroundings. Like if you have some chronic inflammation somewhere, chronic inflammation on a toe, like you are putting on shoes that are not fitting you well, the small toe will usually suffer because of the chronic inflammation. And now the cells around that pressure will change in terms of how they look like on the microscope and how they function. And now when they change in terms of structure and function, that's what we call metaplasia. They change. And you will see that now you will develop a hard muscle around where there is pressure. They are the same cells, yes, but they have changed to become more of protective cells than the normal simple cells that were there. And then on the microscope, you will see them differently. If they were round, you'll find them, they look more of square or something like that. In a simple term, it's the change of cells associated with the environmental factors, either acidity or pressure or some chronic inflammation. Perhaps there is a splint in your limb and you are walking with pain. So the cells will produce a lot of other lysines and histamine and other compositions. They come there and now they change the environment, and the cells that are now there would also change in how they look like and how they function.
Thank you. Thank you, Evelyn. There's another comment. I think this is a question from Peter, but from your presentation, if he followed keenly, he's been answered completely. Discuss the laboratory differential diagnosis of soft tissue lesions, highlighting how the process distinguishes between benign and malignant lesions, as well as different types of tissue abnormalities, and explain how these findings guide appropriate treatment and strategies. Peter, I hope you've been answered, and the rest of us who've read that question. And then another question, Evelyn, it's a case study. 3-day-old child had an abscess on the right upper jaw. Now 1 week old, it has reduced in size. What is supposed to be done in such a case?
3-year-old baby with an abscess.
Evelyn?
Yes.
Mm-hmm.
And an abscess is mostly an accumulation of pus it's like a small sac with pus. An abscess could have a differential diagnosis. If this baby was born through the vaginal canal, they could pick some of the pathogens in the vaginal cavity of the woman, and there could be many. Some of the women have STDs, others have just UTI. And because the baby is too young, they will almost always develop some condition because of that contamination. An abscess, you should not just say it is there and it has not gone properly. We need to investigate. As a laboratory scientist, the best way to go is to get that pus. Go get the pus, even if it is very one drop pus, it has a story. Then advise the client, or if it is your patient, Make sure you do microbiology techniques, you do KOH, and you also do cytology. If you are not able to interpret cytology, you make a good smear, you can just air dry. Then after it has dried, you fix with absolute methanol for around 15 minutes. Then you wrap it well and refer accordingly. You can refer to me, I'll do it for you. Or you can refer to whatever lab you know that is doing the right things, not just a lab. And now, an abscess is just an indicator that there is a problem. So you have to give an answer. What is happening in this abscess? What is inside? You might be shocked to find that it's just a myiasis, a lump, or a maggot coming out from that. Yes.
Thank you, Evelyn, for that. Somebody, Kaburu's Chariot, is asking, what is the treatment of that mite? So you remember that case study you presented on the mite? So they're asking,
Yes.
what's the treatment?
So we have specific type of treatment, and a long time ago we had specific solutions in our chemists. It had very bad smell. I can't remember the name, but if you go, we present you with mites, then you will be given appropriate medication. I know it, but today I haven't remembered. It's usually supplied in a chemist, and you can get it. It's an ointment where you just apply. You don't take any medicine. You can take medicine if the lesions are also infected by secondary bacteria, and you see that it's producing out of pus. But for now, a baby like that one, assuming you have got a gland like that one, you cannot manage that one because that patient needs surgical treatment. Now in surgical pathology, that's where they clean the dead cells away from the skin. They can go invasive procedures to remove those swellings if they discover that there's no cancer inside. So it's a special procedure that will be done by either a surgeon or a clinician with specific skills. But in terms of medication, it should not worry you because your job description is to find the problem. Then after you advise the clinician that I've seen the mite, that is scabies. There are specific drugs for scabies in the workshops, and the patient will heal within less than a week. They will be very happy. Yes.
Thank you. Vincent Ochieng has two questions, but I will ask you to answer one. The first one is on, please clarify for me on laboratory diagnosis of cervical cancer disease. That one I will want us to shelf it for our next presentation where a presenter will be presenting on cervical cancer. This one was soft tissue. And the other question from Vincent is, which culture media of choice is used for culturing bacteria when examining soft lesions, tissues in microbiology lab?
Now,
Take that one, Evelyn.
depending on what you have seen, you see, you cannot culture a tissue. What happens if you are given a tissue from the doctor or on a plate, and there's out of pus and something? So what happens? Mostly you crush that tissue into smaller particles. Smaller particles. You can crush it for smaller particles. And now the choice will depend on the site of where did it come from. Is it a skin? Is it a vulva? Is it from the anus? Depending on what you are suspecting, you have to choose based on the clinical site. Two, even for other techniques, I talked about flow cytometry, I talked about immunohistology. They have specific ways of processing that sample. So, like if you get pus mostly comes from tissues. Then you process according to the protocol and SOP for pus samples. How do you put on makonge? Do you put on chocolate agar? Or where do you put? So make sure whatever you get, it has to go based on the quality control measures. SOP number one, it gives you the direction on what to use and for how long do you incubate. So I cannot be specific because we don't know where this swap has come from. Yes.
Okay. Thank you. Thank you, Evelyn. And there was another question from George asking what is a lesion? And then basically it's an abnormal tissue on or in the body. That's a lesion. So what I want you to take up is kindly on lymphomas from Douglas Muchika. Kindly on lymphomas, what is the difference between Hodgkin's and non-Hodgkin's lymphoma?
So that is now purely cytology and histology and part of hematology. But now, classification of lymphomas, it is a story, it's a big story. But on the microscope, assuming that you just want to, on the microscope, the Hodgkin and non-Hodgkin's. Hodgkin lymphoma is characterized by the red Sternberg cell, a big lymphocyte with a very beautiful double or 3 times nucleus, and it's specific. Very beautiful. It's a big story, but now on this forum, it might not make sense. Kindly, you inbox me, I'll teach you well on what is the difference between the two, but they are just based on the cellular characteristics, what you see on the microscope, and also in terms of immunohistochemistry analysis, after you have seen that this is a lymphoma case, some are undifferentiated, meaning you cannot differentiate them until you do an immunohistochemistry report. So it won't make sense on this platform, but I promise you to give you the best. Kindly inbox me after this. I'll show you how you go about it. But mostly what happens, we do FNA on masses on the lymph nodes, mostly on the neck cervical nodes, or it could even come as a lesion on the skin. But once you see those cells on the microscope, it gives you direction on what to do next. Thank you.
Thank you, Evelyn. There are other questions asking, one more question, not a presentation related. How can one with interest in histopathology become a clinical cytologist like you, and how long is the course? And then the other question is, which are the best cytology labs or histology labs in Kenya? Maybe you can take a minute to answer that, Evelyn. Our time is so much spent.
Yeah, if you want to be a cytologist, I don't know, you went for a degree or you don't know whatever you learned, but the institutions that offer cytology nowadays are many, but if you want the best, I'll refer you to where I came from. I studied at the University of Nairobi. Minimum is 2 years, but you can never achieve 2 years. By grace, mostly you go for 3 years, and it's a full-time course. You have to, like, you forfeit all your activities and go back to school. You stay in class for 3 years completely, and you master all the techniques and procedures for cytology. But other institutions offering cytology, mostly, they don't offer pure cytology. They offer like cytohistotech, which I'm sure is not very comprehensive, because for you to make a diagnosis, you need to be knowing everything. We have Maseno, we have Jomo Kenyatta, we have Kenyatta University, and Maseno and Masinde Muliro. So you can make up your mind, but you want the best, join the University of Nairobi and you will never regret. Yes. And then also on your other question, best labs in cytology, histology, the Kenyatta National Hospital is offering the best because attached to the University of Nairobi Postgraduate School, where we have the pathologists and cytologists examining samples and other specialized clinical pathologists. We have Nairobi Hospital, we have Aga Khan University Hospital. They're offering the best. So if you have a sample, and we also have Lancet and also Kalebi Labs. I know those ones because whoever is working those labs, we have interacted sometimes either in class or on a microscope. So I know who is inside that lab, and they are giving beautiful reports. You can also check on me. I'm here. I can also give you something. Yes. Thank you.
Thank you, Evelyn, and thank you every one of us that was able to join in. I've seen the questions that are still remaining. I will request, can we kindly continue the chat on our YouTube channel? You can ask questions there and you'll be answered. Kindly, can we continue the chat on our YouTube channel? Because of time, we'd like to bring this session to an end this evening. And I would like to thank each one of you that was able to log in today. I know you've learned. I have learned a lot. I'm a cytologist and I've learned a lot. And thank you so much. The YouTube, the link is already shared. Kindly just check The link is already shared on the chat. Kindly go to our YouTube channel. The conversation will continue there. And thank you so much for being on this webinar this evening. Thank you. I'll want to end this and have a good evening.